Until the pandemic came and hit us, I think a lot of people were not quite so aware as to how much our lives are impacted by global events that might start anywhere.
This is a real crisis.
I mean, it's been clear that this was likely to spread in the U.S.
We need to be thinking much more ambitiously.
Climate finance is a very big issue.
We, the Center for Global Development, we're a group that try and see how we can make the international system that supports global development work more effectively.
CGD came about because it was time to focus not only on what developing countries should do, but much more on what the rich world should do.
How do we finance infrastructure in the poorest parts of the world? How do we increase productivity in agriculture? What kind of policy brings out the best outcomes?
Some of our previous work has helped to come up with a kind of innovative financing mechanism that was used to help launch pneumococcal vaccines. We really have researchers and experts here at CGD who come at these issues from multiple vantage points, and I think that's just what helps make our research more rigorous, more rich, and actually more connected to the realities that decision makers are grappling with.
We've been looking to CGD for all of your research and analysis to guide us.
So CGD is nonpartisan. Because of that, over the years, that credibility has given us significant convening power.
Our government highly values the work.
What CGD is about is you can ask those difficult questions that people refuse to ask and actually find solutions.
We're thinking about how climate change will impact migration patterns, how that will in turn have impacts on people's health.
It's challenging to be able to align budget with ambitious programmatic goals, but it can be done.
Every single time that we're able to get it right, it means we're reducing significant poverty.
If you can help to make things a little bit better, that's a good way to spend your time.
Hello everyone, and thank you for joining us here today at the Centre for Global Development. My name is Lorna Guinness, and I'm a non-resident fellow at the Centre for Global Development. I'm a health economist, but I have a particular interest and expertise in costing of health services and the role of costing takes in decision making and in health policy. And I'm really excited to be here today to talk with a fantastic panel about the role of hospital costing systems in universal health coverage. We have case studies from the UK, from India, from Taiwan, and also some other international experience. And I think we've got some great lessons for universal health coverage as this moves forward. So I'm going to give you a little bit of background here, and it's some introductory slides before we go and talk to our panelists. I'm wondering if we can share my slides. Nope, I'll bring my own slides up. Could you share the slides, please, for me? Here we go. If we go on to the next slide, please. Slide number 2. So what we want to talk about today is why investing in national health costing systems really matters for universal health coverage. And as a bit of background, I think we've seen globally that the national health insurance schemes are seen as a key instrument in reaching universal health coverage, but traditional fee-for-service payments that have been found to incentivize hospitals to bill for more services and have been one of the reasons for rapidly growing healthcare costs. Case-based payments have been offered as a potential solution that may be more financially sustainable. Other slides? It'd be, yeah, the slides aren't moving forward. Anyway, to move to a case-based payment scheme requires a systematic and transparent way to set reimbursement rates, to promote efficiency and quality and affordable health services. So in order to do so, we need strong cost data to think about the payment rate. Sorry. No, those aren't the slides. I'll continue without the slides, it's okay. So what do we mean by case-based payment rates? This is when providers are paid a predetermined rate for the condition, for a specific condition or illness. And the amount paid is based on an average cost of care for the patient. So the average cost from admission to completion of treatment, and that's based on the severity of illness. The calculation of case-based payment rates requires a significant amount of data, combined with the sort of average cost of care or the base rate, and a severity weight, or a DR, what was known as a DRG, or a case-based weight. And in addition to that, these rates are sometimes weighted for economic adjustments, such as the budget or the economic or the location of a particular facility or where the care is being provided. The data needs for these case-based payment rates require that we have data, involve resource use data for each of the DRG's groupings and cases. But critically, we also need cost accounting data to inform the overall base rate upon which all these case-based payments are made. Common challenges to obtaining these data, so common challenges to a case-based payment scheme revolve around whether the rate at which the case-based payment is set. So if it's too high, you can threaten the efficiency and the low cost of these services and the budget itself. But yet, if you set the rate too low, you can create disincentives, and providers may not want to participate in the scheme. Theory says that activity-based costing is the best way to inform rates. And in some cases, we use price-based or charge-based estimates. Whichever type of data, or whether it's costing or charges, accurate information on costs and billing are required, and standard costing methodologies. But however, standard costing methodologies are a challenge to implement in many low resource settings where universal health coverage schemes are being set up. So as part of the universal health coverage scheme, we'd like to see cost systems being developed to help inform these case-based payment rates. But this requires a strategy to collect data from a sufficiently representative sample, and this needs to be done in a systematic and standardized way. There are many questions around how this can be implemented, such as whether cost data should be mandatory and provided by all providers participating. Who should collect the cost data? Who should collect the cost data, and whether this should be an autonomous institute or whether it should be the purchaser themselves. The need to develop capacity for costing, and also to establish provider confidence to elicit better quality data. Importantly, we also need to ensure appropriate methodologies for cost data collection. So I'm hoping today that our amazing panelists are going to delve into some of these issues and describe some of the experiences in the different countries' case studies that they have great expertise in. So we can move swiftly on. We've got the first case study coming up is from the UK, and we're very honoured to have Jack Hardman from the UK, who's the head of costing at UK NHS, and also has experience of other countries' costing initiatives. So I'll hand it straight over to Jack to start the case study discussion. Thank you very much.
Thank you very much. So I'll just go straight into it. A bit of brief background about myself. have worked, thankfully, across the world when we're looking at costing and costing systems, all the way from Australia over to North America, out to the Middle East. But today I'm here to talk about what we do here in England. And I appreciate we've just mentioned UK, but what we do here is within England. Wales and Scotland and Ireland are different systems. We are hopefully going to be working with them in the future, bringing this data together, and that will make a little bit more sense later on. So where did we start here in England? Well, and what the reasons behind that? Well, the collection of costs started way back in financial year 1997-98 now, so quite a long time, and that was at an aggregate level. And it was done based in spreadsheets, and data was submitted on an annual basis up to the Department of Health. And the reason for that was to set the tariff, or how hospitals got paid within this country. From then, a lot has happened. Essentially, back in, I think it was around July 2014, England realised that this aggregate level of collection was okay for the setting of this tariff and the prices, but a lot more information could be gained from collecting costs at a patient level. So we underwent a deep dive, spoke with hospitals, tried to work out what they were collecting within their patient administration systems, how that could then be linked to activity systems like theatres, radiology and several others, so that we could still collect this on an annual basis to create that tariff, or payment by results as we call it in this country. But the longer term aim was to feed this data into national programs such as work on efficiency, population health, and removing unwarranted variation. Our mantra, sort of back in 2015 as this started to really launch, was how can we deliver cost efficiencies if we don't know what we spend our money on? I speak with colleagues in the private sector all the time who can't believe that it's taken this long for the NHS within England to really collect costs at a patient level, given the fact that they know where every single widget goes. How do we do this now? We've done it for the last 7 years now. Is we set out a national set of mandated methodologies so that we knew that every single patient was costing the same, or sorry, was being costed the same, not costing the same. That could be from things like when a patient is on a ward, making sure that the cost of that ward is allocated based upon the length of stay. If in a theatre, based upon the session and the minutes within that session, what is over and underutilised within that session. If they have a pathology test, what's the exact cost of that pathology test, the drug. So we really wanted to get down to that activity-based costing, and we knew how and how standardised that was across all of the different hospitals, i.e. when we were comparing two patients sat on an orthopaedic recovery ward, they would be costed the same. We didn't have a trust cost it based upon the number of windows, for example, in there. The reason being is when that data landed with us nationally, we had that comparability. We wanted to look at those inefficiencies. We wanted to look at those unwarranted variations and then use that information via our wider stakeholders, something like Get It Right First Time team that some of you may have heard of, so GIRFT, as to how we can standardise some practices within this country, which may sound unbelievable to some, but there are certain procedures which should be standardised, but we know aren't for reasons like complications. So we set those methodologies up. We set up an annual collection so that we were collecting every single patient that had been seen within secondary care every single year after the financial year end. Alongside that cost, we wanted the breakdown of the currency code that they had, the specialty that they were seen in, and the care setting. Maybe they were an elective or an emergency patient. And then we broke down that cost per patient by resources and activities. So what we get is a very detailed cost breakdown per patient. So every single year we collect about 5 billion data points. The reason being is we might have the resources, the ward that patient is sat on, and the activity might be the nurse that's been with that patient, the clinical, the consultant that's been with them, the drug that's been allocated to them. So we really get what we call a 2D matrix of breakdown of cost. We then work with our collection partner who specialises in digital, although we have just recently merged actually, and they specialise in the collection of this data, and they do two really main things for us. The first is that once they've collected the data, they match that data to national data sets. So we then have access to date of birth of that patient, the sex of that patient, the ethnicity of that patient. But it also gives us access to things like their postcode, their GP, which opens the world up into a number of health inequality metrics, indices of multiple deprivation, such as wealth, education, employment for that patient's area. They then pseudonymize this data for us before passing it to us. But that pseudonymization is consistent, so we don't lose any of that linked data sets. It's also consistent across years. So what we start to really get a picture of is that patient journey. We can compare that patient to population, national statistics. Once that's done, we are able to give all of that information back to trusts through a number of different national publications. So we have our national publication, which goes onto our NHS England website. That is low number suppressed and not at patient level for obvious reasons and identifiable reasons. But at a trust level, they are able to log into national dashboards that we produce in Tableau. We have a self-service tool which allows them to create any kind of aggregation, statistical analysis that they want online using these 5 billion records every single year, allowing them to see not only kind of sort of locally within their trust, but regionally. So we have our integrated care systems, how they can make clinical changes to the betterment of the patient. And that's the big shift that I would say that we've done since the 90s, end of the 90s, to where we are now at the start of 2023, is a shift to putting the patient at the centre of what we do when we're doing this costing work. Some of the challenges that we've had, as you can imagine, 5 billion records every single year is a lot. And although we have some stakeholders that love that kind of 0.0 penny that we collect per patient, they are in the minority. So if we were to start this again, we'd probably look at looking at patient resources. Some of you might know those as cost pools internationally. So aggregating the cost up to a completely different level, so it's easier to collect. So we'd be looking at millions rather than billions of records. We'd be looking at a different collection partner. We're already trialing this, a partner that can receive this information more regularly than annual. So we move from rather than a pull of data from our trusts to a push of data. So a trust could push that to us monthly, daily if they were costing daily, quarterly, and for us to turn this data around very quickly as well. So at the moment, unfortunately, this process takes about 6 months, but we can turn this into a couple of days now. And also, we want to shift focus into our primary sector, so our GP data as well, so we really get that picture of patients. And with that, that is a very, very brief look into what we do here in England. So, thank you very much.
Thank you so much, Jack. That was a fantastic summary of a very, very complex process. So, and I'm sure we'll have more time to discuss the issues. We'll move on to India now, where there's also been some fantastic initiatives in costing. And we have Professor Shankar Prinja here to talk to us. He's from the Postgraduate Institute of Medical Education and Research in Chandigarh and was formerly at the National Health Authority, which is responsible for implementing PMJ, one of the largest health insurance programs in the world. Thank you, Dr. Shankar.
Sure, thanks. I'll try and share my screen and share the presentation. So just confirm to me once you can see, or I'll start then.
Yeah, I can see it.
All right, thank you so much. So as Dr. Lorna and Jack have already alluded to, so I'll try and share the experience from India and within the context of the large public funded health insurance program, which is the PMJY. So for those who may not necessarily know the overall structure and the process of the scheme, just to say very briefly, it's going by the sheer number of people who are part of the social insurance, this tax-funded insurance program. It's the largest in the world, covering more than 50 million households, giving them a hospitalization cover of 500,000 Indian rupees per year, and a scheme that runs digital architecture of IT system, making it a completely cashless and paperless transaction. But one of the things about the scheme, one of the features which is of interest for the present presentation, is that as and when the scheme was designed and when it started in nearly about 4.5 years back, the way in which the provider payment methods were designed, it was supposed to be paid, the doctors and the hospitals were supposed to be paid based on a case-based bundled payment. And as Dr. Lorna alluded to in her opening remarks, that designing provider payment systems which are to pay the doctors or hospitals based on a case-based payment fundamentally need a very strong evidence on cost or prices, and that entire process has to be extremely transparent. So in order to do that, while at the inception of the program or the scheme, the initial prices that were set based mostly on the prevalent rates that were available in the other insurance programs. But there was a need felt that there should be a stronger evidence on cost that should be available, that should guide the decisions around pricing within the scheme. And in order to meet this challenge, a large hospital costing study was designed, which was funded by the government itself, by the Department of Health Research, which is called as the CHSI study, or the Cost of Health Services in India study. And this was a large study which was designed to cover close to about 80 plus hospitals in about nearly 13 states in India, covering the sample of hospitals which were drawn from the district hospitals which provide secondary care, the tertiary care hospitals in the public sector which provide more specialized care, and then a spectrum of private sector hospitals that were sampled using in order to ensure some kind of generalizability of the estimates that come up. And this study used very robust methods of mixed approach of top-down and bottom-up costing methods, collecting very detailed level of granular data on costs that hospitals were incurring in order to provide different types of healthcare services. And eventually, after the launch of the scheme, within a year of the launch of the scheme, there were revisions that were undertaken for prices, which were now going to be based much more on cost evidence. And as you can see that this slide basically shows that to what extent was the kind of cost price differential corrected in the first revision that took place after the launch of the scheme. And what this showed in the last two sets of bars is that when the scheme was launched, actually about 42% of the total packages or procedures or interventions were significantly underpriced. And when I say so that they were underpriced, what it means is that their price was nearly half of what it actually costs to the hospital. But this proportion was actually brought down by more than half in the first revision itself, where the where significant underpriced packages were reduced drastically. Now, the reason why not all of those were corrected was because the cost evidence was coming in bits and pieces, and as a result, corrections were taking place as the evidence was gradually being made available. And what I show on the right side of the slide is that even within the recent revision that took place last year, which was the fourth revision of prices since the last, so it's like almost on an annual basis, the prices were getting corrected. Even within the recent revision, we see that several of packages or procedures that are part of the overall insurance program, they underwent a change in pricing. And you can see that while there were about 120 plus procedures where the prices got reduced, there were 800 plus packages where there was an increase in price as well. And there were close to about 630 where there was no change in the price. So, and if you look at the stratification below, it also shows that they're written across all these 833 packages in terms of how much was the overall increase from the previous prices. So the point that I'm trying to make is that there has been a consistent effort towards a continuous process of price correction, such that the issue of difference between the actual cost that it incurs versus the price that you pay to the hospitals is gradually. And the last year, the revision that took place also led to another major fundamental change in the overall pricing structure, where the prices were corrected for some of the supply side characteristics of the hospitals. So what I show you in this slide on the right side is the evidence from this costing study, which actually showed that hospitals in different types of cities, whether tier 3, tier 2 or tier 1 city, it actually costs you different to treat the same type of if the hospital is located in different cities. And this is because there are different cost structures, there are different rental prices, there are different economies of scale that operate in different levels. And as a result, eventually the cost that a hospital faces in each of the different type of cities is relatively different. And so based on this evidence, there was a new policy of provider payment that was introduced last year, and that led to a fundamental change in the overall pricing structure, where hospitals were not now paid uniformly across all cities, but there was a pricing structure that was created under the scheme. So this was again an application of the same costing study towards making the prices more sensitive to characteristics that are likely to influence the overall costing structures. But we do recognize that there have been several challenges in undertaking such a massive exercise of cost data collection, and these types of large-scale studies are not things that can be a sustainable mechanism for filling the kind of evidence needs for running such insurance programs. And what we see here on this slide is that while conducting this costing study, there were several process evaluations that were conducted alongside. And what this shows is that for different types of data inputs that are collected from these hospitals to derive the actual cost per case treated, there is a range to which the investigators, the data collectors face difficulty in obtaining such similar data. And on a scale of 0 to 10, you can see that there are several data points where you can get a difficulty level of almost close to 7. And these are things which involve, for example, prices of different types of consumables or drugs that are being used in these hospitals, etc. And you spend a lot of time actually collecting information that may not necessarily really constitute a very significant portion of the overall cost also. So as you can see on the slide on the right side, on the figure on the right side, the components of the total cost, which actually comprise just about 10% of the total cost, they actually constitute, it takes about nearly 60% of the total time collecting this information alone. So sometimes the whole conduct of such a massive costing study becomes quite inefficient in that manner. And as a result, there was an attempt to try and establish a kind of a cost surveillance system which is integrated within the overall claim processing of the insurance program. Something similar to what Jack was trying to illustrate in his previous talk, where there is a system whereby hospitals have to report on their costs on a regular. What we tried to institutionalize as part of a pilot in just 5 states is that what if there were systems whereby on every patient that is getting treated, a set of information related to diagnostic tests, drugs, implants, consumables, etc., in terms of both the quantity as well as the price of each of these unit items that are getting consumed for treating a given patient. So this is an exercise that has been going on since the last close to about a year now. But what we learned during this entire process is that it's again a very difficult proposition to ask the hospitals to provide additional set of information. And there are 3 broad factors that posed the biggest challenge to setting up of such a cost surveillance system. The first major hurdle was the lack of enough strong will within the hospitals to provide that kind of an information. And the reason was that these are hospitals that are engaged in service delivery with limited staff, and providing this additional set of information on resource for treating different patients over and above the entire set of documentation that they have to do for claim submission becomes quite a bit of work for them. And so it increases it becomes time consuming, leads to a lot of duplication, etc. Second set of challenge was that it requires trained manpower to provide this information. And while there was initial set of training that went into for each of these cadre of individuals who are involved at the hospital level to provide information, there's a lot of turnover that continues to take place. And so you need a system of trying to train them, build their capacity, keep them motivated so that they give you quality data. And the third, obviously, were certain challenges related to the kind of transaction management system or the IT system that was being used in order to provide this information. And one of the lessons that we realized as part of the last about a year's operation is that for any successful system to not necessarily become a standalone additional activity for the hospitals and the healthcare providers to provide additional information. And it should rather be integrated within the existing systems that hospitals use for their HMIS, for their patient records, or for the purpose of their billing. And and this is something which is still a work in progress, is that the systems for cost surveillance need to be built upon the existing kind of attempts towards digitization of healthcare records or electronic patient records. And one of the fundamental changes that is taking place within the healthcare ecosystem in India is the setting up of this Ayushman Bharat digital mission, which is one set of activities, interventions, or innovations that are being undertaken to create digital public goods that would eventually enable and create an ecosystem of transfer of information across a range of different types of providers, having a kind of a unified health interface, information exchange platforms, and having a common platform whereby there could be exchange of the healthcare claims. So this is one fundamental architecture on which we are trying to create a system whereby the entire information on cost of resources that are involved in patient treatment can also be fetched without any additional workload or burden to the hospitals. So this is my last slide, and what I'm trying to conclude with is that the way forward for institutionalizing cost surveillance systems within the ecosystem of health insurance programs is that there has to be some kind of it has to be a continuous process. This process has to be integrated within the existing hospital HMIS systems or systems that are compliant with the kind of digital architecture that exists. So this is the way forward, and this is the way that we're trying to move forward for establishing the. Thank you very much.
Thank you so much, Dr. Shankar. That's also a very succinct summary of, again, another complex and such exciting initiatives in India, seeing the development and growth of a sustainable costing system there. We're now going to move to Taiwan, another very different experience in costing, in hospital costing. And Professor Nicole Huang from the University School of Medicine is a healthcare financing and policy expert, and is going to provide us some insights into the system in Taiwan.
Hi, Lorna. Thank you for your kind introduction, and hello, everyone. And then I would like to share my slide. So if you see it, please confirm if you see it. Is it okay?
Yes, I can see it now.
Okay, great. Thank you. So it's great. It's a great opportunity to be here to share Taiwan's experience in developing a national costing system for hospitals, and also, most importantly, to learn from other countries. And then, because of the recent frequent media coverage and then the attentions on the political situation across the Taiwan Strait, so I guess the audience are probably now very familiar with where Taiwan is. And Taiwan is in Eastern Asia, and then at the junction of the East and South China Sea. And then, for the audience who are not familiar with the Taiwan's healthcare system, so let me briefly describe it. And then Taiwan has had a single-payer universal health insurance coverage since 1995. And Taiwan's national health insurance program provides flexible access to all medically necessary service, including not limited to outpatient, inpatient, emergency services, prescription drugs in Western medicine, but also covers Chinese medicine and dental care to all 24 million residents in Taiwan. And the program is financed mainly through premium and public budgets. And then in terms of the delivery system, all hospitals in Taiwan and 92 to 93% of the clinics in Taiwan are contracted with the National Health Insurance Program. So basically, the National Health Insurance Program is a monopoly in Taiwan. And since the costing requirement is closely related to the reimbursement policies, so I will briefly introduce you the main reimbursement schemes under the National Health Insurance Program for hospitals. In the slides, you can clearly see that at a macro level, we have a national global budget system with a hard annual expenditure cap. But at a micro level, that the national global budget is allocated to hospitals according to fee-for-service and DRGs. And although we have some other payment pilot projects, but the main micro level reimbursement policies are fee-for-service and DRGs. And since the national global budget is the major reimbursement scheme, and I believe all of you know pretty well that in order to establish the global budget, and you need various kinds of costing data. And then this is the our formulas for setting the global budget for the coming year. And as you can see that the main determinant is a medical consumer price index, and which needs various type and significant amount of costing data. And for obtaining those costing data, we rely wholly on the routine surveys and surveillance systems administered by the national statistical agencies called the Directorate of General Budget Accounting and Statistics in Taiwan. And for example, as we all know pretty well, that the personnel costs normally account for like 45 to 55% of the hospital costs. We estimate that cost from the salary surveys conducted by the National Statistical Office every 5 years. And how timely that can be, then you can guess, right? For the pharmaceutical costs and costs for
Nicole,
medical, yes.
Sorry to interrupt. I think the slides aren't working. So I'm just.
Oh, really?
I think. Yeah. Sorry. I think Shabana's just trying to get the slides to catch up.
Oh, I see.
Sorry.
That's okay. So should I maybe Shabana can help me with the slides? Will it be better?
I think that would. I think she's showing the slides now. I think she's put it on the national global budget slide. Maybe there's.
Okay.
I think you might be a bit further on than that.
Okay. So next slide, please. Yeah, this is the one. And then as you can see from the main determinants of the global budget formula is the medical consumer price index, and then the medical consumer price index includes the cost items. Basically, I list on the table in the slides. And the personnel cost you can see is from the salary surveys, which are conducted every 5 years. For the pharmaceutical cost, for medical alliance, consumable cost, we obtained from the wholesale price index, producer price index, and then for the operating and maintenance or management cost, we obtained it from consumer price index. And then these indexes are probably common also in other countries, and therefore you must know that the all these indices collect some sort of data of medical products. But the problem is that these products, they estimated or they have informations in these indices may not be the core products used in the current clinical setting. So that's the main weaknesses of using these indices. Other than the cost data needed for the global budget, next slide, please. And then for the new medical products, drugs, or procedures which provider hope to be covered by the National Health Insurance Program, they will need to do some cost analysis before they submit their applications. And then with the application, they need to provide detailed information on their estimated costs related to the applications of that specific procedure and product in clinical care setting, including personnel costs, cost of drugs and supplies, and depreciation cost for medical equipment, device, appliances, non-medical equipment, and buildings. And also another item on the cost estimate is the maintenance cost, which is the sum of the 3 depreciation items times a certain percentage that will be determined by the National Health Insurance Program. And then the form that I have is in Mandarin, but basically every new item who wants the provider wants to be listed under or covered by the National Health Insurance Program, they need to submit it digitally to the National Health Insurance Administration. Next slide, please. And maybe you will wonder that how about for the existing pharmaceutical products, how do we adjust or adjust for the prices or set the prices? And basically, we know that the prices of the drugs are dynamic and change over time. So for the drugs currently covered by the National Health Insurance Program, the National Health Insurance Administration will collect the sales information from the pharmaceutical companies every quarter, and purchase information from hospitals also every quarter. And then, so you may wonder whether or not they will be willing to submit it, and they have to, because according to the National Health Insurance Act, that pharmaceutical companies and then medical providers are obligated to report the request information by the National Health Insurance Program. And then also, if needed, that the ad hoc surveys will be conducted for targeted drugs. And those specially targeted drugs are normally expensive drugs, normally drugs who will yield like significant financial budget impacts. All these data collection efforts are put in place to provide references for the National Health Insurance Program to adjust the reimbursement rates for drugs over time. And most importantly, they want to set affordable and reasonable reimbursement prices for both providers and pharmaceutical companies. So all these declaration and reporting are done online through an information system. As you can see that although Taiwan has some centralized hospital costing mechanism in place, there is still a large room for improvement in data comprehensiveness and timeliness. Establishing a hospital costing system is not an easy journey, and we are still struggling after all these years. And then I will end here for now and looking forward to the discussion. Thank you.
Thank you so much, Nicole. I've learned a lot today about Taiwan and the costing system there, and how different it is from many other countries that I've got experience of. So thank you. And I'm noting fully about the mandatory element of the regulation around collecting cost data. We're moving on now to our next speaker, who is Jack Langenbrunner, who I hope is online. Yes, he is. Fantastic. Jack Langenbrunner is a global healthcare financing expert, formerly of the World Bank, and is a consultant for the World Bank and USAID. And I'm sure he can provide some further insights with a more sort of global and international perspective on costing experiences in many of the countries that he's worked in. Over to you, Jack. Thank you for joining us.
Thanks so much, Lorna. Great to be here. And thanks very much to our previous speakers who gave wonderful presentations, case studies. Yes, I'll be more general in my remarks, and I'll be relatively short because I see we're a bit behind on time. So I just have one slide. And, I think as countries want to move to DRGs, they want to have a very big and expensive cost collecting system in place, or at least to start it. And I think that the experience, and I take this slide from Reinhard Bussy's book on DRGs in Europe, and it's interesting because countries got to DRGs through a relatively small sample. So I think the key is you don't need a big sample, you need a good sample. So you need a good sample that distinguishes important characteristics such as urban-rural, such as teaching, non-teaching, and you really need to be careful in terms of how you survey, but nevertheless, you don't necessarily need a big survey. And I think that if you get good data, then it becomes easier in the ongoing years after that to pull in providers who can help, who want to be part of that cost collection process, because they will start to say, hey, I think you can do better. I'm willing to give my cost. I want to see a costing and a pricing system that's not only transparent, but it's fair to me. So I think that's the key. I also want to say that a very good manual that people can pick up online is the Joint Learning Network manual, which goes through both top-down and bottom-up. And the nice thing about the Joint Learning Network manual is that what it does is that it not only gives you the methodology, but it also tells you how different countries, and it was written by a number of countries together. I think it was 4 countries together, but they went through different challenges and how they solved those challenges. So you have the bottom up, the top down approach, but then you also have, well, how did countries come up with how exactly they would allocate the surgical theater space to the actual patient cost? Because in every country you have a slightly different data set, you have access to slightly different data, and you have to make adjustments accordingly. So I think it's a good manual to have and to look at. Now, another thing I want to bring up is cost and charges. So, charges are very friendly, especially if you have a fee-for-service system, because you have the charges already, right? You have the charges in place for your fee-for-service system. I think, often people say, well, let's just use charges. That would be a lot faster. We have a lot of charge data. We have the fee-for-service claims. It's certainly a plus if you're under a deadline. It can give you a fast track to information across hospitals. It can be a plus in terms of being provider friendly as they are generating, for purposes of payment already. And it can be a plus in terms of purchaser friendly in that data is routinely being collected by the purchaser. And it's also easier for updating, right? They're collecting the charge data on a regular basis. So who did it? I know of at least 3 countries that did it at one time or another. Maybe our Taiwanese expert can validate or tell me I'm wrong. But I know of 3 countries: Thailand, the United States, and Taiwan, that really relied on charges to some extent. Indonesia, where I am now, is using it to some extent. They're using a mix of charges and a mix of cost. But I would say to the practitioner and to the purchaser, be careful. Be careful. There's actually some research, a fairly a good research coming from the United States, that charges may be biased. And they may be biased specifically towards urban specialty hospitals relative to, say, small rural hospitals. And so there you may have a real issue in terms of potential equity, geographic equity issue. I think that, the US did extensive studies on the fairness of charges, and then they decided to drop the use of charges, and Thailand took a similar path. They said, yeah, we're using charges, but we're going to go back to cost. So I think that what to keep in mind is that if you're going to use charges, probably the urban specialty hospitals are quite good at detailing charges, right? They're quite good at detailing charges, sending in bills with great specificity relative to their small rural counterparts. And maybe that's where the bias comes in. I don't know. But I think that we have to be very careful if we're going to think about using charges. Maybe there's some blend where we use charges initially, but then we go to a more sophisticated cost survey that can replace those charges. So, I think countries often will look to outside TA to start at the beginning, and that's okay. Although in the case of India, Dr. Shankar has shown us that they don't need outside TA. So I think it varies country by country. But then I think the governments must invest in a team of multidisciplinary types. Those could be economists, statisticians, clinicians, a lot of hard workers with a mind for detail that are willing to be trained as well to pull in the data that you need. And I think, the greater the level of autonomy for providers, the more urgent costing will be for hospitals. So if you have relative autonomy as a hospital, then costing is very important to you because you can respond. You not only want to know your cost structure, but you can respond to that cost structure and figure out whether you're doing a good job or not. And I think that Dr. Shankar's presentation tells us, and this is very important, that once is not enough. Once is not enough, and that as new payment models are phased in, especially when new payment models are phased in, providers are going to respond. They're going to respond to those new incentives. And I think purchasers will need to, keep up, if you will, with the changing cost structures. And they're going to especially see big changes with private providers or autonomous providers who can learn, who can look at the incentives, look at the prices, and then respond quickly to new incentives and change their cost structure relatively easily. It's not going to be as easy for the public providers. They're going to be probably tracking costs better. That's my own experience, that once you go to new payment systems, public providers do pay attention to costs. They do track costs, but then what can they do about it? They're often stuck. They need approval higher up to change equipment, to change bed structure, to change inputs from human resources, and so on. So I think that's the challenge. Let me stop there, Lorna, so that I stay on time and we give everyone a chance for questions and discussion. Over to you.
Thank you very much, Jack. That's great reflections. I'm particularly interested in this issue about the difference between cost versus charges, as well as you say, talking about using charges in the costing system or to inform prices can be very useful. It's quite an efficient way of accessing the data, but can lead to problems in terms of bias. But also, I've read some analysis where they found that the hospitals respond to that in terms of it's a kind of strategic charge, so that they can bias the reimbursement rate as well. And often the private providers have a lot of information at their fingertips that they can use that the public sector doesn't necessarily have.
Very nice. Very nice. Yeah, I would agree with that. Very nice.
Cool. So thank you, everyone. I think we've had some really interesting stories from the case studies, and I'm trying to work out the best way to interrogate. I'm just going to ask if there have been any questions coming in on the stream, or whether to go to my own questions. Okay, so we haven't got any questions so far. I hope we'll have some coming in later. So the thing that working in costing that I have done, I think that the thing that I really struggle with is how to incentivize providers to come on board and submit data. And when we're talking about long-term sustainable costing systems, I wonder if Jack, Nicole, Shankar, if you have anything. Oh, and Jack Langenbrunner has already got his hand up to provide some insights into how to incentivize providers to submit their cost data and take part in the national costing system.
Well, Lorna, you may already know about the Australian model, but one of the interesting things that the IPA does, the Independent Pricing Authority, they have a voluntary way of bringing it's voluntary. Hospitals can involve themselves in this costing process, and in return, they're not paid, but in return they are given the information about their hospital, and they're also given league tables about how well they're doing relative to other hospitals. So you may find you can go through the cost data for your hospital. They're not named hospitals, but they're it's hospital 1, hospital 2, hospital 3, and then there's certain characteristics. Then there's the cost data on each of them, and you can compare your hospital with other hospitals, and you can say, hey, we're doing pretty well on surgical theater cost, or gee, we're not doing so well when it comes to handling diabetics when they're admitted into our hospital. So that is the way they're doing it. Now they have a bias sample because it's voluntary, right? And this is not a webinar where we can go into how they might adjust, but I think that's a very interesting approach. The other way is to pay, or the third way would be to contract, right? If you want to contract with the purchasing authority, you're going to have to give cost data if you're selected. Again, it's not every hospital that will be selected. It's probably a small sample, let's say a 5% sample, but you may be asked to participate. And then finally, I would say it's very important to have a kind of a back-end audit, right, by an independent firm, because even though people may report costs correctly, precisely, they may not have a full manual as to how they're actually supposed to do it, and they may not always do it correctly or in a fully standardized way across hospitals. So I think a third-party audit is still needed. Over to you, Lorna.
Thank you, Jack. I just wanted to get other reflections on that. Jack, Nicole, Shankar. Is that I suppose, Jack, is that something that you use in England?
So here in England, we're quite lucky, you could say, in that the collection of costs is mandated. So every hospital is signed up to what we call a provider license. So within that provider license, we are allowed to request for the submission of patient level costs. I know in other systems that Jack's just mentioned, millions of dollars have been put into the purchase of software and positions. Certainly in Europe, we hear of it's a voluntary collection of costs, and if you fall within a certain standard deviation, they'll pay for that position to continue costing. But here in this country, kind of the incentive, if you will, outside of the mandation is providing that information back as quickly as possible without any kind of trust pseudonymization that Jack's just mentioned, so that you can benchmark yourself against other providers and look at that full population. We do try and do case studies around the patient level data ourselves, matching it to things like health inequalities and outcome data, provide that back to trust to again continue just that relationship with them, although it is mandated.
Thank you, Jack. I think Nicole, you talked about the mandate as well. Is that right?
Yes. And then in Taiwan, let me just briefly respond to Jack's comments about like Taiwan's is mainly a charge-based costing system. Yes, it's true. Yeah, for pharmaceutical drugs that we are trying to collect costing data for hospitals, right? Just like in my presented in my slides. But for all other non-pharmaceutical services, they are still charge-based. And then the mandatory scheme that institute in the National Health Insurance Program is because that we have tried a voluntary action and efforts, and then but we encounter like strong resistance from the hospitals. So like instead of have voluntary scheme, we have a mandatory scheme instead. And then for our payment schedules or payment schemes for global budget, we do incorporate like quality of care rewards. And so that part is different from the that part is separate from the formula. So it's an additional bonus, quality bonus for that. Yes. Thank you.
Okay, great. Thank you. And so, Shankar, talking on behalf of maybe more nascent costing systems coming up, maybe you could reflect on what a mandate could look like, or would be whether that would be feasible or not, particularly in, I suppose, in a situation you have in India where you have a very pluralistic system and an extremely active private sector that the government is working with. How do you think a mandate would go down, or do you think there might be some alternatives?
Yeah, I think the issue of getting the hospitals on board for this kind of a system is something as an issue that we've also faced in India. There are couple of things that both the payers and the hospitals have tried suggesting in terms of how to make the systems work. From the provider side, the frequent requests that come in that could perhaps incentivize setting up of such systems could be either some kind of support for some human resource that could help, streamline such system, or if there could be some additional kind of financial incentive. This is not something that is possible. Even some kind of a priority in processing of the claims for hospitals that agree to participate within the cost surveillance system is something that seems to be quite a sufficient incentive for hospitals to join in. This issue of making this participation into a cost surveillance system for empanelment under the scheme but I think that it seems that it might lead to some degree of it may give a pushback to the overall acceptance of the scheme in general. So by and large, there has been in the short term, there is encouragement to that kind of a system.
Thank you, Dr. Shankar. I've realised now that we've managed to go over time. So I'm very sorry. I think we're going to have to break it up there. And I still have many questions, and I hope we can just continue these discussions going forward. But yeah, I think what I wanted to do is sort of leave with something that Jack Hardman said at the beginning, which is how can we develop cost efficiency if we don't know what we spend our money on? Just underlining the importance of implementing these costing systems and getting them in place while we build up as well, sort of global health builds up the universal health coverage schemes. And with that, I just want to say thank you very, very much for your involvement. I hope everybody who's listened in has enjoyed and learnt from the case studies. And yeah, and that's it for now. Thank you very much.
Thank you, Lorna. Thank you all.
Thank you.
Thank you.